So once we have reviewed the framework for staging and grading and the different criteria that we should use, let's see some clinical examples. So in this particular example you have in the screen, this is a stage 1 periodontitis case where we can evaluate interdentally the CEJ. The CEJ is evident, and therefore it's easy to evaluate when we have minor attachment loss. In this particular case, we have 1 to 2 millimeters of clinical attachment loss, and we don't have presence of pockets of more than 4 millimeters. So this is a very incipient periodontitis. When we evaluate the radiographs, the full mouth x-rays, we see that the presence of bone loss in at least 2 non-adjacent teeth affects less than 50% of the root length. And these incipient periodontitis cases, tooth loss is not present, or if present, is not due to periodontitis cause. So let's see an easier case, because the stage 1 case is difficult to detect unless we can have clear evidence of the cemento-enamel junction. Stage 2 is easier to detect because clinical attachment loss interdentally is between 3 and 4 millimeters. And again, this patient is characterized by not having very deep pockets, 5 millimeter or less, but we need always to discard presence of pseudo pockets that sometimes may confuse us when evaluating probing pocket depths. So this is one of these cases. As you can see, the patient has not lost any teeth, and the patient, when we evaluate the radiographs, we can identify bone loss which is limited to the coronal third in at least 2 non-adjacent teeth. That is between 15 and 33% of the root length. And it is obvious in this particular patient that no tooth loss is present. So let's move to the next stage by severity, which is stage 3. Here is very easy to detect because the interdental clinical attachment loss is 5 millimeters or more. And this particular patient, as you can see, has not lost teeth, and basically tooth number 27 that is lost is the only tooth that was lost due to periodontitis. Since this is less than 4 teeth, then we are in a stage 3 situation. You can see the charting of this particular patient, and both in the upper and in the lower jaws, you see very deep probing depths. You see the presence of furcations in the maxillary first and second molars. You see presence of very deep pockets associated both with the upper and lower premolars and molars, and you see a very high percentage of bleeding on probing. So with all this information, we can clearly ascertain that in addition to the stage 2 complexity, we have very deep probing depths, which are not pseudo pockets. We have vertical bone loss of more than 3 millimeters. We have furcation involvement, classes 2 and 3, and we have a moderate ridge defect. And you can evaluate these aspects both in the periodontal chart and in the full mouth x-rays. Here is a clinical example of stage 4, which in terms of interdental clinical attachment loss is similar to stage 3, that is presence of cal loss of more than 3 millimeters, but similarly bone loss extends beyond the middle third of the root, but in this particular situation, stage 4 patients have lost more than 4 teeth due to periodontitis. And you can see in this situation that the patient has lost the lower molars, first, second, and third molars, and some of the upper maxillary molars equally. And you can evaluate only by clinical inspection the degree of attachment loss. If we do a periodontal chart, we evaluate clinical attachment loss, but we also evaluate the presence of the need for complex rehabilitation due to the masticary dysfunction as a consequence of the tooth loss. In many of these situations, the teeth have drifted, there is bite collapse, and those teeth have also flared out, also leading to a severe ridge defect, which can be very clearly evaluated in the full mouth radiographs. When dealing with the grading, here is an example of a 50-year-old woman, never a smoker, that has a clear presence of a stage 3 periodontitis. But we have previous records of this patient, and this patient has not lost any further attachment in the last 5 years. This patient also has the typical phenotype of having very heavy biofilm deposits, lots of plaque and calculus, with moderate levels of destruction. And this, if we calculated the bone loss to age ratio, this would be less than 0.25. A patient that is non-smoker, patient that is non-diabetic, is normal glycemic, and therefore this is a clear example of a grade 1. This is a clear example of a grade B. This is a patient that is 74 years old. This is a patient that has not lost more than 2 millimeters in the past 5 years, and we do have previous records of this particular patient. The phenotype is such that the deposits, the biofilm and calculus deposits, are commensurate to the destruction and the age of the patient, and therefore this percentage bone loss to age is between 0.25 and 1. And although the patient is diabetic, the HbA1c levels have always been below 7%, and therefore the grade B of this patient has not been upgraded to grade C. Here is another example of a grade B periodontitis stage 3 patients, where the patient has bone loss which is less than 2 millimeters over the 5 years. The destruction is commensurate with the biofilm deposits, and there is a percentage of bone loss to age, again, between 0.25 and 1. Here is a clinical example of grade C. This is a young patient, 28-year-old female, heavy smoker, and as you can see by the clinical and radiographic records, this is a patient that has lost definitely more than 2 millimeters over the last 5 years. Even though the destruction may be proportionate to the level of biofilm deposits, due to the age, we can ascertain that the progression has been a very rapid progression. Percentage of bone loss to age is clearly over 1, and beyond that, sees a patient that smokes more than 10 cigarettes per day. These have been very simple examples of how we should stage and grade our periodontitis patients. You should remember that you don't need to populate every single cell of the grid. You need to go step by step from screening to final diagnosis, and in those periodontitis cases to the final staging and grading. Of course, grading belongs to the patient according to the progression and presence of risk factors. So the grading can be revised depending on the patient himself. A smoking patient can turn into a non-smoking patient. A diabetic patient can be fully controlled of their glycemic status. And of course, good compliance of the patient can also turn a rapid progression into a no progression once the treatment has been implemented. So with this staging and grading, what we aim is to classify our periodontitis patient and to individualize not only the staging, which depends on severity and complexity, but also the grading that depends on the patient, him or herself. And in that way, we go towards personalized and precision dentistry, which is basically our goal for how we need to deal with patients in the future. Even though you may think this is a complex classification system, it is much simpler than you think, and if you follow these steps, you will implement it very easily in the management of all your patients. I hope we were able to transmit to you the importance of following this very important classification of periodontitis. Thank you very much.